Thank you very much for that kind introduction, and greetings, good morning to everyone. Unfortunately, I have no conflict of interest to disclose. Okay, so my remit from EHA was to speak on abnormal platelet physiology, but I felt I could knit in some newer research that we're conducting in the lab that would probably be well in step with this Congress, where there seems to be a lot of malignant hematology. So just by way of a broad overview of what platelets do and what they're most famous for is this process of forming an aggregate, generally in response to tissue injury at the endothelium. Now I'm told I can actually use that pointer. Tissue injury, or in response to altered shear conditions. So platelets are very sensitive to changes in fluid shear stress, such as when the lumen of a vessel narrows, such as around the formation of a coronary plaque. This immediately activates them, and via the agency of two receptor systems that work together, the glycoprotein 1b95 complex, which primarily binds VWF, and glycoprotein 6, which primarily binds collagen, this triggers an activation response, forcing the platelet to slow down and adhere to the endothelium, to a site of injury, and to activate and secrete, eventually resulting in formation of an integrin-dependent platelet aggregate. So this is famously alpha-2b beta-3, which binds fibrinogen. So each of these receptor systems are unique to platelets. They're only found on platelets and megakaryocytes, glycoprotein 1b95 complex, glycoprotein 6, and the integrin alpha-2b beta-3, all unique to platelets. And so antiplatelet therapies are generally trying to block this interaction. So most famously aspirin, but also clopidogrel, which blocks the feedback mechanism by which ADP released from platelets during this process feeds back to further activate and amplify the activation of the platelets and lead to recruitment of additional platelets. So clopidogrel and aspirin, which is a COX inhibitor, also stops these activation pathways. There are some other reagents that target alpha-2b beta-3, but the signature of all of these events is that, therapies, is that they have unwanted bleeding side effects. So they're almost too effective at blocking this process, and it leads to bleeding. So just returning to this idea of what's happening here, these two receptor systems bind their cognate ligands and trigger signalling pathways that lead to the activation of the integrin. And so this integrin, which is in a resting state, 80,000 copies per platelet, sitting in a bloodstream that has milligrams per mil of fibrinogen, they don't interact at all. But once this system is engaged, immediately, within seconds, this integrin now becomes able to bind fibrinogen, and we get the formation of an aggregate. So one other consequence of engagement of those receptor systems is the shedding of the receptors from the platelet. So I'm just going to focus mainly for this presentation on glycoprotein 6, but engagement of the receptors by the ligands, so collagen-related peptide convulsin, which is a snake venom protein that only binds or activates through GP6, or collagen, the native ligand. This Western blot, we can see levels of GP6 are quite stable on the surface of resting platelets, but once they're engaged by their ligand, we get a loss of the intact platelet receptor of about 60 kilodaltons and the appearance of a fragment of GP6 in the supernatant. And this, in this experimental system, takes a little bit longer, but in vivo, and particularly under other combined conditions of activation, we can get this shedding event. So this is a host of work that we've described over the past sort of 15, 20 years, we know that this shedding event is caused by the ADAM10 metalloprotease, which sits in the membrane of platelets. It's a ubiquitous metalloprotease. It can cleave a sequence right down on the extracellular juxtamembrane region to produce this fragment of GP6. And more recently, we described that exposure of platelets to shear will also trigger the loss of GP6 from the platelet surface. So shown here best in a Western blot, by flow cytometry, where intact GP6 on the presence of untreated platelets is if the platelets are exposed to a level of shear stress that would approximate what we might see in a stenotic vessel, we can see a loss of the intact surface GP6 from the platelets and the appearance of a soluble GP6 fragment by in an ELISA assay developed in our lab. So the blue bars represent the loss of surface glycoprotein 6 from the platelets, and the black bars are the increase in the soluble fragment of GP6. And we can see here exposure to a shear stress for even a brief period of time can trigger that shedding event. So this just this is an overall summary of what's actually going on in a cartoon format. So using an antibody that is directed against the intracellular portion of glycoprotein 6, we can detect that tail fragment in response to shear stress, increasing amounts of shear stress, and it's blockable by a metalloprotease inhibitor. So this is a shear-dependent event that doesn't require the ligand, and so we believe that this is, so it occurs in the absence of a ligand, so there's no signalling pathways required for this shedding event. And to cut a host of work, abbreviate a host of work, what we believe is happening is that this is part of the normal wear and tear of a platelet circulating through the vasculature. And this is how, this is one of the guiding principles behind a platelet aging. It's the loss, I focused in on glycoprotein 6 here, but the same events also happen with glycoprotein 1b alpha, the VWF binding subunit of that complex. And so over time, just exposure to different levels of shear stress, just for brief periods, but regular exposure, we can see a loss of these receptors. And it's an irreversible loss. We believe this fragment doesn't have any sort of vascular properties on its own. Work that I'm not going to go into today, glycoprotein 6 works best as a dimer. It can self-dimerize, and so the fragment, as far as we know, is released as a monomer. So we don't believe, the evidence is, there's no evidence that this fragment has any vascular effect on its own. So in that regard, it's different to CD40 ligand, for example. So just to summarise this part of the work, glycoprotein 6 is present on resting platelets, and under conditions of activation or exposure to ligands, the ADAM10 within the platelet surface is able to release the collagen binding portion of this receptor. Other work that I won't talk about today, activation of coagulation and particularly factor 10A can also trigger this effect. But we have a host of approaches in the lab now that we can measure this event, and we think that this is a terrific platelet-specific marker of activation, because glycoprotein 6, unlike P-selectin, for example, is unique to platelets. It's also found on megakaryocytes in bone marrow, but it's unique to platelets, and so soluble GP6 is a marker of activation events. So we developed an ELISA to measure the shed fragment of glycoprotein 6, and this is just the data looking at a large healthy donor cohort. And long story short, The plasma soluble GP6 levels present in a range of, with an average of about 18 nanograms per mil, plus or minus 8 nanograms per mil, and the levels of soluble GP6 don't appear to be affected by age or gender, or sex differences, and they also are not determined by the platelet count, which is important. So we found no correlation with between the level of the circulating platelets and the soluble GP6 levels. So this means that this marker may be important and useful in thrombocytopenia samples. And so this is work from our group as well as other groups around the world looking at different cohorts of samples from people with atherothrombotic diseases and, interestingly, autoimmune, inflammatory and bone marrow disorders where there's been either measures of soluble GP6 or surface GP6 and evaluations of the significance for that particular disease or pathology. So that we can show this association between soluble GP6 and different pathologies. But the big question that, of course, everyone is probably silently asking is, what is it? How is it related to clinical outcome? And is it temporal? Is it what's the timing of measuring of the sample? How important is that? So I'll just go through a couple of the cohorts where we've identified the importance of loss of receptors from the platelet surface with functional outcomes. And so this first group is a trauma-induced coagulopathy group where we were able to measure from 39 trauma patients where the sample was taken immediately the person enters the emergency room. And then the sample taken back to the lab, we can see differences in how platelets, first of all, respond in an aggregometer to collagen and collagen-related peptide. This is a GP6-specific agonist. This is GP6 as well as other collagen receptor agonists, but we can see clear differences in how the platelets respond in light transmission aggregometry. It was less evident with an ADP being used as an agonist. P-selectin levels were also elevated in the patients, already indicating there was a level of platelet activation. And then in an adhesion on collagen assay, where collagen is coated to a chip and then we can image the formation of the thrombus using a shear-related activation of response. We can measure area under the curve for these adhesive events, and we saw a clear difference between healthy platelets and platelets from people who had suffered trauma. So there was a clear loss of function by several mechanisms, as several approaches shown here. And then if we did some further dissection of the cohort, we could see there were differences between survivors and non-survivors in terms of competency to bind to collagen in this assay, and also in the aggregation response, clear differences between survivors and non-survivors in the ability to respond to collagen or collagen-related peptide in an aggregation response. So we had the opportunity to actually delve a little further than what you would normally be able to do in a clinic, and we measured levels of the receptors important for that adhesion event on collagen under flow, glycoprotein 6 and glycoprotein 1b alpha, and we can see clear differences in levels of these receptors by flow cytometry. No difference in the level of the beta-3 integrin. So these are the two receptors that are shed from the surface classically, although no one had reported this in trauma-induced coagulopathy. And also the levels of soluble GP6 were elevated in the plasma of the trauma group. This level of soluble GP6 correlated with severity of the trauma. And by using D-dimer and other measures of coagulation, we could see a difference between samples from trauma patients where trauma-induced coagulopathy was present versus not identified using classical diagnostic tools. And again, using ROTEM, so thromboelastography, we could correlate the level of soluble GP6 with a reduced hemostatic competence, so in this case, a reduced clot strength using the XTEM clot amplitude time at 5 minutes, and also a relationship between fibrinogen levels, or an inverse relationship between fibrinogen levels and soluble GP6. So in conclusions, we were able to show that receptor loss occurred after trauma, particularly during DIC, and this translated to reduced hemostatic competence and increased mortality. And in a second cohort that might be of interest to my colleagues who are talking today, we had opportunity to look in an autoimmune thrombocytopenia group. So these were 310 people sent for HIT testing, heparin-induced thrombocytopenia testing, and in a subpopulation of these people who hadn't received any blood products as part of their treatment for suspected HIT, we could measure soluble GP6 levels. So these are people with an autoantibody to heparin, platelet factor 4, and there is a known activation of platelets leading to the classical thrombotic events if in the worst case of HIT. So we were looking to see whether soluble GP6 would be able to inform on that activation process. And what we were able to find that in 256 patients, we could separate into bleeding events or no major bleeding events, and we could see a difference in the release of GP6. So when more soluble GP6 is released, an association with a major bleeding event. Interestingly, and still up for discussion, is why we could not see any relationship with, for example, the amount of HIT antibody or serotonin release assay, which are the classic assays for HIT. So whether the release of soluble GP6 was part of that engagement of the platelet surface by platelet factor 4 heparin antibodies, or related to some other component of this pathology, we're still evaluating. Soluble GP6 was also significantly associated with 30-day mortality. And then just in a couple of cohorts of people living with cancer, we were able to measure soluble and surface GP6 in a group with stage 0 or 1 chronic lymphocytic leukemia. And again, we could see that when there's a bone marrow disorder, we also could find this detachment of increased levels of soluble GP6 and lower levels of surface GP6. There's no correlation in the healthy donor population, that's these black dots here, and there's no correlation also in people living with bone marrow disorders such as leukemias. But we wondered whether this would be important because many of these patients will be treated with reagents and therapeutics which can impact on platelet responsiveness and have known bleeding side effects. So just finally, in some more unpublished work from our group, primarily a talented PhD student in my group, we had access to blood samples from people with Waldenstrom's macroglobulinemia. It's a B-cell lymphoma with signature bleeding, bruising, and thrombocytopenia events. And so we felt that it would be important to look at these types of effects on the platelets in people living with Waldenstrom's, because they're treated primarily with tyrosine kinase inhibitors, which are known to also interfere with platelet responsiveness. So in this group with Waldenstrom's, they did have a slightly lower platelet count, but it was not terribly low. Only 3 or 4 had platelet counts below 100. But we could detect lower levels of glycoprotein 1b alpha and glycoprotein 6 in these individuals. And so these are people who are just being observed. They're not under any treatment. And this also translated to a difference, again, in clot firmness using a rotem fib-tem analysis. So generally, the rotem values were normal for these people. They were all in the normal range. It was just when we evaluated platelet contributions, we could see that there was differences in how those platelets from people with Waldenström performed. We're still not sure of how to explain this. The levels of soluble GP6 in these people are within normal ranges, so we don't believe it's a shedding event. In this case, it's not an activation leading to this loss. Perhaps it's a signature of a disturbance in thrombopoiesis in the way the platelets are produced. So that's being evaluated now. So just to summarise, ADAM10, a disintegrin metalloprotease, is the enzyme responsible for release of the ectodomain of glycoprotein 6 from the surface of platelets. And we believe that this measure of plasma glycoprotein 6 is a good indicator of platelet activation in the patient. So this is, a patient signature event, not needing donor platelets, and it informs on what's actually happening in the patient's bloodstream to the platelets. And this is still work in process, but we know, work from our group as well as a number of other groups, is that these receptors on the platelets rely on a density, a specific surface density, in order to best function. And so once we begin depleting that surface density, this can lead to loss of platelet function and bleeding events. Likewise, too much of a receptor, so when this normal system for regulating the receptor levels is somehow ablated, this can lead to thrombotic events. That's also work published from a number of groups, for example, the Gawaz group in Germany. And some of the work that I've shown you suggests that abnormally low levels of glycoprotein 6 could be associated with an increased risk of bleeding. So just finally, just in the last couple of slides, I'm not a clinician, I'm a fundamental scientist, and so we do a lot of these sorts of experiments where we have a reservoir of hyaluronated or citrated blood that we pass across a collagen coated chip, and we measure adhesion events using confocal microscopy as well as several other high-end imaging modalities. And we can control the speed at which the blood crosses this chip using a Harvard syringe pump, and we essentially look at this process of platelet aggregate formation on collagen. We can segment the formed thrombus and make 3D reconstructions. But what we were interested in, of course, is to see if we could link how levels of these receptors influence this ability to form an aggregate. And so just in using some of the confocal images that I've just described, in this slide we're looking at a thrombus where the platelets were stained with DIOC6 as well as an anti-glycoprotein 1b alpha antibody and an anti-glycoprotein 6 antibody. Taken together, they make a rainbow type image, but if we remove the platelet dye, the green, we can see that there's definitely regions that are enriched for glycoprotein 6 versus regions that are enriched for glycoprotein 1b alpha, suggesting that under the conditions that we form this aggregate, we were able to trigger shedding events and change platelets, change the architecture of the thrombus by changing the levels and the density of the receptors on the surface. This is summarised in this brief cartoon where the core and the shell of a thrombus, this is a concept that has been led by a number of groups around the world. This is not this has not come directly from our lab. So Skip Brass's group was led the way in deciding on, or in talking about a core versus shell architecture. And so we feel that we have a core that has a loss of glycoprotein 6 but increased levels of glycoprotein 1b alpha, and a more loosely defined shell region where there's retention of glycoprotein 6 but loss of glycoprotein 1b alpha. So these are the receptors that are binding collagen and von Willebrand factor. And so we feel there's implications here for, different ways that we could begin to think about targeting this thrombus in a clinical scenario. So just to summarise, we've talked a little bit about platelet adhesion receptor levels, how they're regulated under flowing blood conditions, and exposure to ligands and shear stress triggers loss of those receptors almost immediately. We've looked in a couple of cohorts and identified that we can see the loss of the receptor, either loss of intact surface receptor or decreased soluble fragment in disparate groups, including a trauma group, as well as in people living with malignancy, and linked those observations with loss of function and bleeding events. So we believe these types of measurements would have good clinical implications for decisions around therapeutics and the use of therapeutics. I'll just finish by thanking all the members of the team, in particular Simone and a former postdoc in my group, Samantha Montague. Thank you.
Thank you very much for that presentation. And as I said, we're going to hold questions to the end. So I'm now going to ask the second speaker to come up and give his presentation. So can
invitation and the kind introduction. These are my disclosures. In my presentation, I will try to introduce the topic of platelet refractoriness from a diagnostic and a clinical point of view. In particular, I will focus on the definition of platelet refractoriness. I will talk about non-immune and immune causes of platelet refractoriness. Then I will briefly describe the diagnostic workup for patients suspected for immune platelet refractoriness, and on the possibilities we have at hand in the daily clinical practice to provide this patient for possible compatible platelet concentrates. Platelet refractoriness is far from a rare problem, occurring in the daily clinical practice up to 30% of patients in the hemato-oncological settings. And this is also confirmed by a number of publications on this topic which have been produced over the last 20 years. The definition of platelet refractoriness. Usually, platelet refractoriness is referred to a failure to achieve an adequate response to platelet transfusion in terms of post-transfusion platelet increment. But we cannot rely on the mere absolute platelet increment after a platelet transfusion. And two major factors have to be taken into account. The first factor is the time. Platelets need at least 1 hour to equilibrate with the intravascular space. But we know that in the clinical practice it could be difficult and problematic to measure the platelet increment at 1 hour. This is the reason why a 10 minutes platelet increment has been proposed and used in the clinical studies. Another important thing is the correlation between the 1-hour platelet increment and the increment in 24-hour. This can be very important and relevant for the differential diagnosis of platelet refractoriness, being typically the immune mechanisms of platelet clearance rapid. The second factor is the distribution volume. Different patients have different blood volume, and this comes into the play and should be considered. Some formula for the calculation of platelet increment takes into account the total blood volume itself as for the percentage of platelet recovery. Other, probably most common used calculation as for the corrected count increment, use the body surface area to normalize for the volume. If we look at this calculation, and for simplicity, we use an average body surface area of 2 meters square, and we divide it by 4 to 10 to 11, which is approximately the content of platelets in an apheresis bag. We see that this formula gets much easier and becomes as the same of dividing the platelet increment per microliter by 2. In any case, most of the studies define platelet refractoriness as a 10 to 60 minutes CCI lower than 5,000 per microliter in 2 consecutive evaluations, if possible, taken after dispensing ABO compatible platelet concentrates. However, a CCI lower than 7,500 per microliter or a PPR lower than 30% are also accepted and used. If we look at the value of 5,000 per microliter CCI, is it easy to understand that the critical value of the platelet increment is around 10,000 per microliter, which is commonly used in the clinical practice as a rule of thumb to identify possible platelet refractoriness. Looking at the causes of platelet refractoriness, one has to be aware that immune platelet refractoriness are much less prevalent than non-immune platelet refractoriness, and a combined type of refractoriness is not rarely simultaneously found in the patients. The causes of non-immune platelet refractoriness are a myriad: fever, sepsis, active bleeding, accelerated platelet consumption, particularly by diffuse intravascular coagulation, splenic sequestration, graft versus host disease, medications, poor platelet quality, and long storage of platelet units. These situations rely on very different mechanisms of platelet clearance, including the interaction of platelets with neutrophils, with pathogens, with activated endothelium, deserialization of platelets, and some of these novel mechanisms are about to be defined and will probably have in the next future also an impact on the therapeutical option for this patient. What is important to remember from a clinical point of view is that most of these non-immune causes of platelet refractoriness can be ruled out with a good medical history and physical examination in spite of the era of precision medicine. This is not trivial to remember, particularly when referring a patient suspected for immune platelet refractoriness to a transfusion medicine servicing, as the testing for antibody and the searching for a compatible platelet concentrate is costly, also in terms of time, and cannot provide the patient with a real benefit if the patients are not well selected. About immune platelet refractoriness, the vast majority of the cases are due to anti-HLA class 1 antibodies. Platelets display HLA molecules on the membrane and lower level of ABO antigens. Class 1 consists of 3 loci, being the loci A and B relevant for platelet refractoriness. Pregnancy is a major cause of alloimmunization against HLA. This is known since many years, and the risk increases with the number of pregnancies. More than 30 years ago was seen and demonstrated that a similar risk to get immunized against HLA antigens was found in patients with multiply platelet transfusion, and this was no long after well demonstrated and clarified by a cornerstone study which enrolled patients affected by acute myeloid leukemia that were randomized to receive leukodepleted or non-leukodepleted platelet concentrates. And the patients receiving leukodepleted platelet concentrates had a significantly reduced risk to develop platelet refractoriness overall, to get immunized against HLA, and to display an anti-HLA antibody-related alloimmune refractoriness. And this was due to the residual leukocytes present in the platelet unit. It is also important to remember that the immunization against HLA doesn't mean an HLA antibody-dependent platelet refractoriness, being the latter present in less than 1/3 of patients with HLA antibodies. Platelet antibodies can be directed also against the platelet-specific antigens located in the surface glycoprotein of platelets. These antibodies have a major role in neonatal alloimmune thrombocytopenia, but plays a minor and very rarely are involved in platelet refractoriness. It is important to remember that these kind of antibodies are often observed in conjunction with anti-HLA antibodies. The last group of antibodies I would like to mention is the drug-induced platelet antibodies. Diverse categories of medications can be involved. These are a list of drugs for which at least 10 cases of drug-dependent thrombocytopenia have been described. This is out of the aim of this presentation, but it is important to remember this point when analyzing the clinical history of a patient with possible immune platelet refractoriness. When a suspicion of immune-mediated refractoriness has been posed, the diagnostic workup consists of the screening for HLA antibodies, and this can be done with two major categories of tests: the solid phase assays using beads which are coated with HLA antigens that can to which can bind the patient's antibodies, and then they can be eventually detected by using anti-human EEG and the flow cytometric principle, for example. The second category is the cell-based cytotoxicity assays, which exploit the antibody-dependent complement-mediated cell lysis. In our institution, we use a solid phase test as a screening tool and a cell-based cytotoxicity assay for the confirmation and the typing of platelet antibody. The search for other platelet antibodies, specifically specific platelet antigen, can be done and performed as a second step when, for example, by using a monoclonal antibody mobilization of platelet antigen assay, the MAIPA test, when the HLA antibody screening is negative. Once an immune-dependent, an alloimmunization has been confirmed, the search for possible platelet concentrate which are compatible can be done by cross-matching the patient's serum with a panel of donors' platelets, or to search for a matched or a compatible donor. The cross-matching is rapid and does not require the typing of the patient and the donors. However, it should be repeated very frequently, as the antibody reactivity can change very rapidly. And the risk of future alloimmunization is not prevented. This risk can be prevented by using HLA matched or compatible platelet concentrates. HLA compatible platelets are platelets lacking the antigen to which the patient's antibody are directed. This searching takes time and can suffer from a small donor pool, particularly for patients with rare HLA phenotypes. In terms of efficacy of the post-transfusion CCI, the three methods seems to be similar and significantly better than a random selected use of platelet concentrate. However, the CCI should be assessed regularly over time to confirm and to monitor the efficacy of one of the strategy has been used. By way of conclusion, platelet refractoriness is a complex process and still represents a major clinical problem. When dealing with patients with suspected platelet refractoriness, a correct assessment of post-transfusion increment of platelets is required. The non-immune causes of platelet refractoriness are prevalent and probably underestimated in the diagnostic workup. Anti-class 1 HLA antibodies are the main cause of immune refractoriness to platelet transfusion. And the antibody testing, as well the search for compatible platelet concentrates, should be performed in selected patients. I will finally thank the group I belong to, directed by Professor Greinacher in Greifswald, and you all for the attention.
What I'd like to do in this final talk is move it a little bit further now towards the clinical aspects of how we manage patients with refractoriness. I've introduced myself at the beginning, Professor Simon Stanworth. I haven't got any direct financial conflicts to declare, but I am going to be discussing some trials I have led and been involved with. What we've been hearing about, particularly in the last talk, are these situations, these clinical cases that we're all very familiar with. You'll be able to see, I've just illustrated here 2 examples, but I put them up because I wonder whether sometimes we're kind of oversimplifying things. One immediately looks at the top case and one starts to think of that non-immune refractoriness that we've been hearing about. But of course, even in the second case, where we might be starting to think about immune causes, for example, these are patients who will be developing a fever, might be developing sepsis, will be on antimicrobials. So I think sometimes we just need to think a little bit about the setting. What I also want to do in this talk is try to think a little bit more about the randomized trials of platelet transfusions. Why am I doing that? And I guess my argument is that at the end of the day, whatever degree of matching we're looking at, the main treatment that we're thinking about for our patients are platelet transfusions. And particularly in the context of some of those cases of non-immune mediated refractoriness, we do have more clinical randomized trial data that may be saying something about how we should be using platelet transfusions. And in fact, towards the end of this talk, I'm going to mention a randomized trial that we were involved with that looked at the role of better matching in the case of immune-mediated platelet refractoriness. Again, I'm going to be fairly quick with my little background because that's been covered in the last talk, but I think we're all comfortable with some of the definitions, often in the textbooks, about what we mean by platelet refractoriness. I do again wonder whether some of these threshold counts have been defined a little arbitrarily and what they actually mean. And actually fundamentally, and that will be a message that will come through in this talk, what we really want to be looking for are clinical outcomes. What's the impact of different ways of matching platelet transfusions if they're needed? What is the impact, not so much on increment and change in platelet count, but what are the clinical outcomes? Does it matter? I think most of us will accept that it does matter. But of course, by pointing out these associations, what it's not saying to us is that if we put a different strategy in place, or if we use different platelet components, for example, different matched platelet components, will that affect and improve these clinical outcomes? And I think that's still where we've got to be a bit more restrictive and more careful with how we interpret some of these. We've seen similar data supporting this, and I think, again, non-immune factors seem to be by far and away the most and the biggest group of patients that we're going to be dealing with. When I was thinking about this, you often just benefit from thinking about practice, good epidemiological studies of practice. And I just picked this one up to illustrate this. So Marianne Nellis in the US led a series of studies around platelet transfusion practices in critically ill children. Many of these children will be sick. What she was doing in this study was really observing what happens to these children. There was also close monitoring for complications of bleeding, and it was a prospective cohort study that was undertaken in a large number of paediatric critical care units globally. For me, this just summarises one of the key findings. Now, if you look at this on the left-hand side, on the vertical, you'll be able to see changes in the platelet count. And then these were categorised by different groups of children, those that developed more significant bleeding, top left, minor bleeding, or other, in the context of no bleeding, bottom right, prophylactic transfusion. But I think all of us would look at these scatter plots and look at all those dots. There is huge variability in the responses to transfusions here in this group of critically ill children. And in fact, in a number of these cases, you can actually see the platelet count seems to be reduced after a transfusion in these children. So lots of reasons to explore as to why this might be the case. I haven't got time in this talk, but I think we sometimes underestimate the potential influence of some of the factors in the donors, the donation factors. And I put this up as an example of that. But I think there's still a little bit of uncertainty about how important the degree of ABO matching is on platelet recovery. And in this study, it wasn't a randomized study, but it was just asking questions here about outcomes in patients with intracranial hemorrhage. I think there are many other areas where perhaps we need to look more closely at that platelet component. Not, for example, you might want to think about storage age of the platelet component as a further example, but also recognise that there is a lot of variability between bags of platelets. They're not all the same. So when we come to think about those majority of our patients who have some degree of non-immune refractoriness, which, as I've already shared with you, is common, what do? Well, the textbooks would often say, first and foremost, treat the underlying problem, and I think we would all recognise that, and we'd all agree with that. But secondly, there's often this comment that comes up about, well, think about the platelet component you're giving. Think about ABO, compatibility, maybe fresher platelets, maybe more frequent use of platelets, but of course there are risks. And I think this is where I want to just present with you some of the randomized controlled trials looking at how we use platelet transfusions pragmatically in a range of different patient groups to see what you think. There are a couple of other treatments that might be considered in these patients. One might, for example, think about antifibrinolytics, tranexamic acid. I think it's worth saying that there are a couple of large randomized trials looking at the role of tranexamic acid in patients with hematological malignancies. These have finished. I think there was a large one conducted in North America, which was presented at ASH, and there's another one between the UK and Australia. Neither of these, to my mind, have been published yet, and so I think we wait for a little bit more data on the role of tranexamic acid. It would be difficult not to put one slide up describing the risks of platelet transfusions, and I just thought I'd show this from SHOT. Many of you will be familiar with SHOT, which is the National Haemovigilance System that we have in the UK. It is a reporting scheme for all reactions related to transfusions. And I thought this was a very interesting figure that was in the most recent annual report. So you'll be able to see on the horizontal axis the year of reporting, and then on the vertical axis the number of reactions per 10,000 units issued. But I think overall we can all see here that platelets are associated, or the most common component associated with reported reactions. Again, I haven't got time in this presentation to go into what those reactions are. Further information is on that SHOT website. But I think we have to bear this in mind when we're thinking about platelet transfusions. I also noticed, and I've already been doing this in this presentation, how I've been sharing with you the role of platelet count. We look at a platelet count, we look at a platelet count threshold before a transfusion, we look at an increment of platelet count. And I think all of us are assuming that actually platelet count is helping us to predict bleeding. But is it? This is one slide just to make us think again about how strong is that relationship. So this was taken from a North American Play-Doh trial, which looked at different platelet doses, and it looked at bleeding. And you can see here, and this was a large number of patients. On the horizontal axis, we've got the morning platelet count, and on the vertical axis, the number of days with bleeding of WHO grade 2 or higher. And I think most of us would look at that. You might be drawn to that small uptick on the left-hand side, but I think most of us would probably be fixing on the relatively horizontal line of this graph. There doesn't seem to be a strong relationship between platelet count and clinical bleeding. So that takes us on. I've kind of mentioned a little bit about platelet transfusions. You know, what are the randomized trials telling us? This schematic diagram just summarizes what's been happening. And there have been a number of these trials which are comparing different strategies for how we use platelet transfusions. And many of these groups of patients in hospital practice will be those with non-immune refractoriness. If the trial is done properly, then you can see that if there is a difference in clinical outcomes, then we can relate that back to the different way of using platelet transfusions, which might be done by dose or it might be done by threshold, for example, platelet count. Now, if I kind of try to take a step back at these randomized trials and try to think a little bit about what are they saying as a whole, well, actually, I don't think there's much evidence across all these trials for a difference in set of results for hemostatic outcomes, bleeding, between the trial arms. So, for example, if we think about bleeding and we think about rates of bleeding, we don't see increased rates of bleeding in the restrictive arm. Can I give a couple of examples of that? I've mentioned on the bottom of this figure, I mentioned that Play-Doh trial a bit earlier on where I was looking at platelet count, and I was relating that to prediction for bleeding. But there'd been a number of studies looking at different doses of platelet transfusions. The bottom one here was that Play-Doh one again, and this just summarizes what this schematically, what this trial showed. So it looked at platelet counts in these patients, hematological cancers with platelet counts below 10, and these patients were randomized into effectively low dose, standard dose, and higher dose for platelet transfusions, and they looked at rates of bleeding and they reported them. I think all of us would accept that that percentage rate looks remarkably the same, irrespective of which arm the patient was allocated to. But I might take it a little bit further and say there's no evidence of a dose effect for platelet transfusions in this large cohort of patients that have been randomized to platelet transfusions. What about a few other studies here? Because I think there's one other point to come out. Again, in the UK and Australia, we did a trial looking at prophylaxis versus not giving platelet transfusions to patients with platelet transfusions. So again, in a way, the kind of intervention arm was being even more restrictive by how we use platelet transfusions. What were the results in this trial? So this is summarized here, where we reported, again, rates of WHO grade 2 to 4 bleeding. Again, most of us might be looking at that and thinking, well, there's a fairly small difference there. We're going from maybe 43 to 50%. But maybe there's another message that's coming through from this particular slide and the one I showed you earlier on that Play-Doh trial, which is that despite giving a prophylactic platelet transfusion policy, many of my patients are still experiencing bleeding events. So perhaps it's saying something here about what are we doing with platelet transfusions for clinical bleeding. And in fact, very briefly, but some of you will be very aware of this, but when we looked at some of the subgroups in this prophylactic trial, I think if you looked at, for example, in the groups of patients having autografts, autologous transplantation, really there was no difference in the outcomes of clinical bleeding. And this will again include a large number of patients who had fever, who would have had varying degrees of non-immune platelet refractoriness. Okay, what about some other studies? So I think I started off talking about children, critically ill children, but there's been another large randomized trial thinking about how we use platelet transfusions in neonates. Now, I know this is a hematology conference, and this is a very different patient population for many of us, but one would suppose that non-immune platelet refractoriness is as much of an issue in this population of critically ill babies as it is in some of the other groups that we've been hearing about. So again, a randomized trial was done. This was done in the UK, Netherlands, and Ireland. Neonatologists have tended to use platelet count thresholds higher than we would expect to see in the context of bone marrow failure. And in fact, at the time of doing this randomized trial, we compared outcomes in babies receiving multiple platelet transfusions to maintain platelet counts above 50 or 25. What were the results of this study? Well, you see here, so the primary outcome was a composite outcome of major or severe bleeding or mortality by day 28. And you can see in the table, there's the results for the 25 and the 50 arm. But actually, as you're looking at those numbers and the percentage rates, it's actually the outcome of major bleeding and mortality was greater in the babies in the more liberal arm for platelet transfusion. And this was statistically significant. If you like to think about it another way, numbers needed to treat, numbers needed to harm, it appeared that for about every 14 babies treated with a 50 arm, you would expect to see one extra major bleed or death. So this is not just saying now that giving, there's no problems with giving fewer platelet transfusions. What we're beginning to see here is perhaps some evidence of harm coming through with how we use platelet transfusions. Now, this is a slightly kind of what I might call a hypothesis-generating study, but I was trying to think about ways of presenting data on all those randomized trials that might be looking at non-immune platelet refractoriness. And you can see here the second trial down is the neonatal study, and there are other studies as well. Now, they all maybe recorded bleeding in slightly different ways, but as a whole, there really doesn't seem to be much of an effect of platelet transfusions to have an impact on clinical bleeding. I haven't got time, but we've been hearing about it in some of the earlier presentations to think much more about why this might be happening. And I think one of the take-home messages I have from this work is that we increasingly need to think about the fact that platelet transfusions, platelets have non-hemostatic effects on immune pathways, and perhaps we need to start thinking about those, which might be increasingly relevant in some of our sick patients with varying degrees of non-immune refractoriness. So in this first part of the talk, I hope I've given you a little bit of an update around platelet transfusions in that setting. I don't think this changes from the general direction, which is we want to be treating the underlying problems, treating the patients, the underlying causes. But I think hope I've shared with you perhaps some of the reticence from the trials about an approach that might recommend more liberal transfusion policies. What I wanted to do more briefly in the second bit of the talk is just focus a little bit more on some practical ways in which we're using platelet transfusions. So I want to follow up from the previous speaker and think a little bit about what we might be able to do, what the literature is saying about these different ways of thinking about better matched platelet components in the context of immune platelet refractoriness. Now, I'm not going to repeat some of the slides, but what I do want to emphasize again is that the current approaches, and some of you will be very familiar with this, but the current approaches to HLA matching or providing HLA-compatible platelets or providing cross-match compatible units are very resource intensive. So for us, for those of you who work in blood transfusion services, you'll be very familiar with the need to maintain large donor panels of individuals with different HLA types to be able to support these patients where we consider HLA matching of platelets is needed. And of course, if we don't see the increments, whether we see an impact on bleeding is another question, but if we don't see the increments, then we do either repeat testing or further testing, or as we've been hearing about, we might look for additional testing, such as human platelet antigens, HPA. And only at that stage do we start thinking about random platelets. So these are the more traditional ways that we've been hearing about, that the laboratories that will support us to manage alloimmunized patients with platelet refractoriness. But again, it's just making the point that behind it, there are a lot of costs and resource implications. Now, this data that we have so far is very much based around platelet increment. And if you look at the literature, and this is a table just trying to summarize these different approaches. If you look at the table and you look at the 6th column, what these studies have been trying to do over the years is either comparing these different approaches for how we might match platelet transfusions, but they've all been retrospective studies. They're looking back and they're trying to ask questions based on that retrospective study design, whether an alternative way of providing matched platelets has an impact on the patients. And of course, we'll all be very familiar with the limitations of the retrospective type of studies. And I think until recently, this has been a limitation with how we might better improve matching of platelet transfusions for patients with immune causes. A colleague of mine, Judith Marsh, who some of you may know in the UK, led a UK study where we actually thought we'd do this in the context of a randomized trial. So what this trial was doing was comparing, and I'm going to show this in the next couple of slides, a different way, an epitope-based approach for HLA matching compared to a standard antigen matching approach. But one of the points I want to share with you is that this is trying to move it from those kind of retrospective studies to something that is now a prospective interventional study. This figure summarizes what we can do. So that conventional way of looking at matching for platelets is based on changes at the antigen level. But the technology is now available for us to look in much closer detail at triplets and eplets, different really detailed ways of thinking about these epitopes. And the computer algorithms allow us to do this matching at the allele level rather than the antigen level. And for us in the UK, in the blood service, there were questions here about, well, should we be introducing this new technology for allele level testing? What are the advantages compared to the standard approaches? And I think it's probably fair to say that in the past, we would generally not consider doing some form of prospective evaluation, but thinking about, well, we'll introduce it, and then we might retrospectively go back and look at some of the outcomes. So this study was completed, this was published. We didn't find any difference in outcomes. So firstly, we looked at changes in platelet count increment using epitope matched platelets compared to standard matched platelets. But secondly, we also looked at a range of secondary outcomes, including clinical outcomes, such as bleeding events. So this allowed us to declare non-inferiority. If we were to use a different strategy, an epitope epigenome-based strategy for platelet transfusions, it was no worse than the standard way of matching platelets for these outcomes. However, if we do that, it can have an effect on those resource implications, because it means that we don't need to have, for example, that large donor pool available for us. So just to put that in the context of some numbers, NHSBT is the blood transfusion service for England, and actually at the moment it's providing over 10,000 HLA match units a year. It is a huge amount of resource, and it therefore has to be underpinned by a significant panel of HLA-typed donors. This epitope way of thinking about the provision of platelet transfusions may mean we don't need to have that level of support providing and underpinning the provision of these. Now, of course, randomized trials such as this, you should always be a bit more cautious. I've just presented one trial. Don't get me wrong, it was a difficult trial to do, but it was a trial of a diagnostic test. And I wonder whether sometimes when we're thinking about these areas, we don't think about the more providing more scrutiny, more research scrutiny in those areas as we might do for drugs. So what I hope I've shared with you in the second bit is that I think we are now moving to an era where we can think about prospective randomized studies of different approaches. We need to do this because the current standard way of thinking about platelet matching in immune causes of platelet refractoriness is very resource intensive. I've indicated that there may be some benefits for using a different strategy, for example, an HLA epitope match strategy, but I think further work does still need to be done on that. I know that we are seeing advantages in those groups of patients who are highly sensitized. So what I hope I've done in this talk is share a little bit with you about some of the more practical, the clinical ways of using platelet transfusions, both in the context of non-immune causes of platelet refractoriness. I think we still have important questions around how we're using platelet transfusions, but I see there's more spotlight now on what platelets are doing beyond hemostasis. And I think we need to think more about these diagnostic strategies, and we need to think about the prospective studies that will enable us to compare them more effectively. And my final slide, just to indicate that for those of you with an interest in transfusion, EHA has created a new scientific working group in transfusion. Some of you may have joined us in March where we had a virtual meeting, but we're moving towards face-to-face meetings. We're particularly trying to target in Europe juniors and early career researchers to try to foster better networks for collaborative research in transfusion and supportive care. So please do feel free to make contact or to follow up with this, or particularly to encourage some of your early career investigators to come. Thank you very much. Now, very keen to hear from you and to hear some questions that you might wish to ask us. There are microphones I can see in the auditorium, and if you do come up, please just introduce yourself. Otherwise, we'll start asking some questions here.
Yes, okay. I'm Riitta Lassila from Helsinki, Finland. Thank you for an excellent session. I'm sort of curious, why do we just measure the number of platelets, the increment of platelets, as platelet bags contain like microvesicles, which could be hemostatically active, and that's the part of the bag, but then there's a part of the patient who has maybe low factor 13 or something else explaining the bleeding tendency. So I think we should maybe measure something more. And I would like to hear from Elizabeth's great talk about the role of microvesicles during these shear events, etc. Thank you.
Yeah, that's a very good point, and my colleagues could probably answer that better as to why we don't measure more things. What I can tell you actually is that in a bag of apheresis platelets, the way the platelets are made, produces a lot of soluble GP6. So that's one of the reasons I know soluble GP6 on its own is not probably pathological or having a vascular effect, because every time we transfuse a patient, they are receiving a healthy dose of this soluble fragment, probably with no side effects. In terms of microvesicles, yeah, you're absolutely correct, particularly in older bags. So bags of platelets, the life in Australia has just been extended to 7 days, and presumably that would mean more microvesicles produced, which are quite procoagulant, so you would think actually they would be of some benefit. But I noticed Simon, I think, mentioned using younger bags of platelets as a better transfusion product.
Yeah, I totally agree with the question. I think we fail to appreciate what we're actually transfusing, and we're not just transfusing platelets. And I guess another way I think about that is I sometimes look back on some of these trials I was sharing with you, and I'm concerned we missed an opportunity to perhaps take some samples of the platelet component before a transfusion and after a transfusion, and in the patient. We should be thinking much more about, and it is a biological product, the microvesicles, there's a lot of other factors in there. And I think I'm still, look at studies like the one I shared with you on the neonates, which for me is asking, well, what is it in that bag that might be causing some of this harm? And we don't have good specifications for the components we're doing, and just talking about a platelet count doesn't capture all those other things. So very much agree.
I am Balduini from Italy, Pavia. A question to Dr. Stanworth. In the past, it has been hypothesized that infusion of intravenous immunoglobulin would be useful for increasing the increment of platelet after transfusion in patients with refractoriness. But I didn't see any new data on this matter. Have you any information of this hypothesis of effectiveness of high-dose intravenous immunoglobulin?
I haven't seen any recent data on immunoglobulins. I would need to go back and check, but for example, the study I shared with you on pediatric critical care did try to collect a whole range of different interventions that were sometimes used. And I don't remember there were any cases of immunoglobulins. So maybe it's something, we need to think about. I haven't seen any recent data unless anyone's aware of that. And it's not something that I would commonly use in my practice.
Hello, this is Olga Lopez from Salamanca in Spain. I have, first of all, to congratulate you all. 3 great talks. And I have 2 questions. The first one is about platelets that have been pathogen reduced. So I'm not sure if there is any clear evidence saying that these platelets have more risk of platelet refractoriness or less? That is the first question. And the second one is about the use of platelets, not for bleeding, but for prophylactic use. I mean, they are still, this use is the most frequent one, but it's still, I still doubt that these platelets are effective for preventing bleeding. So I wanted to hear the comments from all of you about these questions. Thank you.
So there are two questions there, one on platelet reduction, and the second was on the, just coming back again to this question of the effectiveness of prophylactic platelet transfusions. So I'm happy to take the second one, and I'll see if one of my colleagues wants to say something about the platelet.
Is it pathogen-reduced platelets? It's probably...
We don't use pathogen-reduced platelets in the UK, so...
This is, of course, an interesting point, but there are no data about the use of these platelets to reduce platelet refractoriness. And in the anecdotal reports, it has not been shown that there is a difference about in the setting of refractoriness.
I think there is some pooled data, as you may be aware, from some of the trials indicating that it might be an effect of more of these pathogen-reduced platelets, might have an effect on platelet counts, platelet increments after platelet transfusions. So I think that is something that has been, is described in the literature. I think there are one or two of the technologies that are being evaluated in further studies at the moment. I think I'm particularly keen to see what some of those results will show. But I know that, that their outcomes will include data on how multiple platelet transfusions, what's the requirement, what's the need for additional platelet transfusions if you were to introduce that. And I think there's data in, that have been. You may know, but in Spain, I know you've been using these pathogen-reduced platelets, and again, I've seen some of that data there pointing to higher needs for platelet transfusions.
Simon, just to follow up on the IVIG question, which is terrific, you showed a slide looking at cryoprecipitate and fresh frozen plasma comparing with platelet transfusion, and with making the point around, I think, adverse events with platelets vastly greater than these other products. So do you use cryoprecipitate instead of platelets ever? In Australia, we use this product a lot more because of the remoteness around delivery of product in certain circumstances. So I'm just wondering whether cryoprecipitate could step in certain scenarios.
I've seen some data on mixing experiments trying to evaluate whether fibrinogen, however given, might, I suppose, might be a platelet sparing effect. But I've only seen that in the context of mixing studies in vitro. I don't think it wouldn't be an accepted practice to look at, look at using a fibrinogen product in the context of someone with a low platelet count. So certainly it wouldn't be a practice in the UK.
Do either of you have a comment on frozen platelets? Instead, a nice little 5 ml vial versus a big 500 ml bag, and the use clinically.
I have a question now as well for Professor Stenworth about what about the slow infusion of platelet transfusion. I know there are at least one clinical trial ongoing, which can probably definitely clarify the point.
So before coming to that, and maybe you know more about that, but I think there was a question before about prophylactic platelet transfusions, which I haven't forgotten. Yes. And I think the question was, can you please discuss again the role of prophylactic platelet transfusions? And I find this a difficult area. I presented very briefly with you the results of our UK-Australia trial of prophylactic versus no prophylactic platelet transfusions. There was, in addition, a German study which looked at not giving prophylactic platelet transfusions. And I think my message, the takeaway, is that in some groups of patients, and this is where it gets difficult, in some groups of patients there may be a role for prophylactic platelet transfusions to reduce bleeding. So if you remember one of the tables I showed you, I showed the autograft data and I showed you the data for groups of patients with AML. And I think there were some differences there. But I think I take away from that two messages. I think one of them, which we're probably not very good at doing, is thinking about patient factors. We tend to have guidelines that consider, for example, a platelet count threshold of 10, if you go with prophylaxis, in all our groups of patients. But we know clinically that the risk of bleeding is very different between these groups of patients. I think the autograft patient stable in remission is very different to an AML patient at presentation and induction. And so I think one of the messages I take away is that we need to try to move towards how we might individualize giving platelet transfusions, which we don't do very well. And I think the second point with view to the question that was asked was, I think all these trials are still saying to us that despite giving prophylaxis, so I think the question was framed along, I'm giving prophylactic platelet transfusion, but actually, even if we give a policy of prophylactic platelet transfusion, if we record bleeding, a lot of our patients are experiencing bleeding events despite giving platelet transfusions as prophylaxis. So I think that's saying something a bit more fundamental about the fact that bleeding's occurring, but it's really not related to that platelet count. And I think maybe again we need to move away from that. So I think those, I'm just going back to the two questions from the speaker. And then there was a question about frozen platelets, and maybe you know.
I do not have.
I've had a chance to look at some, fundamental research around frozen platelets. You look at them under the microscope, they don't look very healthy, but they would be procoagulant and given in the same volume. So we're getting the same volume into a patient, and a membrane, if you like, getting back to the vesicle comment, maybe it doesn't matter about it being a functional platelet. It's more about the procoagulant surface that the assembly of the coagulation pathway can go ahead and formulate on. So again, frozen platelets are also under evaluation in Australia too, mainly to deal with the remoteness issue. You've got no experience with them? No.
We've got no experience. I think we're almost at the end of the session, but the question that Professor Gardner just made me think something I'd like to ask her. So we're in BSH in the UK, we're updating our massive hemorrhage guidelines at the moment. So slightly moving away here, but we're still talking about platelet transfusions. But we really struggled with what to say about how to use platelet transfusions in trauma. And I noticed you presented some of the work describing platelet dysfunction in those groups of patients with trauma. And I wonder whether you've got any insights into, well, it's too late now, but what we should have said in our guidelines that will be coming out around platelets and the problems of a platelet count in a patient with major bleeding.
Yeah, so the trauma group is fascinating because these were blunt force traumas and car accidents, so presumably people going to work relatively healthy, little to no, sort of morbidity, mortality considerations, and yet their platelets were severely dysfunctional within 4 hours of arriving in the emergency department. In terms of, they all did get blood product, of course, in that setting, and still had bleeding events. So, no, nothing firm that I could add other than probably what's already done now. Using Rotem to guide those transfusion events appears to be really taken up well in the trauma setting. And probably because of that, there's a level of healthiness of the blood vessels that there's probably an effectiveness there for transfusions that may be missing in people with more chronic, long-term disabilities, pathologies.
One more question, and I think this will be the final question.
Yes, Professor Zaya, Italy. A question for Professor Gardiner. Do you have any data regarding anti-GP6 immune thrombocytopenia? Do we have a more bleeding phenotype if compared with anti-glycoprotein 2B3A?
Yes, in a word. So I think Carlo talked about the MAPA. So the MAPA, which detects the antibodies in ITP, does not, as far as I know, look for anti-GP6 antibodies. So they're very rarely reported, but they're probably underreported. They probably do exist. So I know of at least 10 to 12 separate cases. They all are picked up because the patient bleeds out of step with the platelet count. They might have a platelet count of 50, but they're having bleeding events. And then the light transmission aggregometry in response to collagen is deficient. So that's a classic presentation of an anti-GP6 antibody in ITP. Yeah.
Well, I think, thank you very much for your attention and questions. I'll now draw this session to a close. Thank you.